Welcome to the Deep Dive, the show where we unpack complex topics and really get you straight to the heart of what matters. Imagine yourself in the whirlwind of a labor and delivery room. It's, fast-paced, machines are beeping, there's this intense energy, and amidst it all, you just want to understand everything that's happening, especially concerning the tiniest patient in the room.
It's that moment where information is just paramount, isn't it? That feeling of wanting to truly grasp the critical details, particularly when it's about a new life.
Absolutely, and that's exactly what we're digging into today. Fetal monitoring. This is a remarkably critical skill in maternal newborn nursing. It essentially offers us a real-time window into the well-being of both the parent and the baby throughout labor.
Right. And our mission for this deep dive is really to transform what often seems like, complicated medical jargon into clear, actionable knowledge. We'll demystify the core concepts, common practices, and the crucial interventions related to fetal monitoring. By the end, you should have a really solid understanding of how the different monitoring methods work, what those patterns on the monitor strip actually mean, and probably most importantly, the vital actions taken based on those readings.
Yeah, and we've drawn insights from, top-tier nursing educational materials and practical clinical explanations to give you a true shortcut to being well-informed. You'll gain key distinctions, key insights that will let you confidently understand this vital aspect of maternal care. So, ready to decode the baby's secret language. Let's
Sure.
jump in.
So to start off, let's talk about why we monitor in the first place. What's the fundamental purpose of fetal monitoring? Well, at its core, fetal monitoring provides this continuous computer-assisted auditory and visual assessment of the fetal heart rate, we call it FHR, and the parent's uterine contractions, or UC. It's essentially our constant watchful eye and ear on the baby during labor.
And how do we actually, listen in on that tiny heartbeat and those contractions? What are the main tools we use?
Okay, so we have two main approaches, external and internal fetal monitoring. External monitoring is what you'll typically see first. It uses two key devices placed right on the parent's abdomen.
Right, I've seen those. One's the ultrasound transducer that goes over the baby's back, detects its heart movements, gives us that heartbeat sound. And the other is the TOCO device, right, that senses the uterine contractions. How do nurses make sure they're putting them in exactly the right spot?
Well, that's where Leopold's maneuvers come in. It's a sort of systematic way nurses palpate, feel the abdomen to figure out the baby's position, like where's the head, the bottom, the back. The goal is to find that point of maximum impulse, the PMI, which is typically between the baby's shoulder blades. That's the sweet spot for the ultrasound transducer. The TOCO, on the other hand, that goes on the fundus, the top of the uterus.
The top, okay.
Yeah, because that's where contractions usually start and are strongest.
But I've heard external monitoring has some limitations, especially with contractions. Is it true it doesn't actually measure how strong they are?
That's a really crucial point, yeah. External monitoring tells you when a contraction starts and ends, so you get duration and frequency, but it doesn't give you a number for intensity. For that, we rely pretty heavily on the parent telling us their pain level.
Ah, okay.
Also, things like significant maternal weight, a higher BMI, can sometimes interfere with getting a good continuous reading.
Hmm.
The ultrasound may just have more tissue to get through.
All right.
And of course, the parent's moving around a lot, the devices can slip.
Sure, that makes sense. So when external monitoring isn't quite cutting it, maybe, or you need more precise information, that's when you might move to internal monitoring. What does that involve?
Exactly. It's a bit more invasive, yeah, but it offers much greater precision. The main tool here is the internal fetal scalp electrode. It's this tiny, tiny wire that's gently inserted through the cervix and attached just to the outer layer of skin, the epidermis, of the baby's presenting part, usually the head.
Okay.
And this gives us a direct, really accurate ECG tracing of the baby's heart rate.
That sounds like a significant step. When would a provider actually decide to do that?
It's typically reserved for situations where there's some concern about fetal distress, maybe, or when really precise data is needed. For example, if we're adjusting medications like pitocin to help labor along.
Pitocin, yeah. The synthetic oxytocin often used to start or boost contractions. That stuff really gets things moving.
It does. So having that direct line on the baby's heart rate helps make sure we're using it effectively and, importantly, safely without overstressing the baby.
Makes sense.
But there's a really critical requirement for internal monitoring. The parent must be at term gestation, usually around 37 to 38 weeks.
Why is that so crucial?
Well, it's simple but vital. To insert this monitor, the amniotic sac, the water, usually needs to be broken. If you did that in a preterm pregnancy, say at like 29 weeks, you're basically committing that baby to being born prematurely and likely needing NICU care.
Wow, yeah. That really underscores the importance of gestational age in these calls. Are there other times internal monitoring would be avoided?
Definitely. Things like really thick fetal hair can sometimes cause artifact, which is like interference on the tracing, making it hard to read. And because of infection and transmission risks, it's contraindicated if there's an active herpes outbreak or if the parent is HIV positive because you are breaking the skin, even just a tiny bit.
Okay, safety first. And you mentioned another specialized internal monitor, one that can measure contraction intensity.
Yes, that's the intrauterine pressure catheter, or IUPC. This is key because, unlike the external TOCO, an IUPC does give you a number, a numerical measurement of the intensity of the contractions.
Okay.
This is incredibly valuable for providers. It can help them justify clinical decisions, like, for example, if contractions just aren't strong enough to dilate the cervix, it might support the decision for a C-section. It can also sometimes be used in specific cases, like washing out meconium-stained fluid before delivery, though there's always an infection risk with warmed fluid you have to watch carefully.
Got it. So external tells us when contractions happen, internal scalp electrode gives us the precise baby's response, and the IUPC as the critical strength of those contractions. That really clarifies the whole tool set. Now that we understand how we listen in, let's really dive into the baby's language, those intricate lines on the monitor strip. If you've ever seen one, it looks like this continuous zigzagging graph. How do we even start to read it?
Yeah, understanding the layout is definitely step one. So the dark red lines on the paper, those each mark 1 minute. From one dark red line to the next, that's a minute.
Okay, 1 minute.
And then each tiny little box within those minutes, that's 10 seconds. And crucially, the top part of the strip always shows the baby's heart rate, the FHR, and the bottom part tracks the parent's contractions, the UCs.
Baby on top, contractions on bottom. Got it. And the grid is our timer. What's the very first thing you look for when you're looking at the baby's heart rate?
You determine the baseline fetal heart rate, the FHR baseline. This is basically the average heart rate of the baby between contractions measured in beats per minute, BPM. The normal range for a baby is generally 110 to 160 BPM.
110 to 160.
Right. And it's important to pick one specific number as a baseline, allowing for maybe a plus or minus 5 beat variation around it. Any obvious jumps up, accelerations, or dips down, decelerations, those are excluded when you figure out the baseline. They get classified separately.
Okay, so find the average, pick one number. Next up is something called variability. This sounds like it's about how much the heart rate is fluctuating, like moment to moment.
That's exactly it. Variability refers to those minute fluctuations in the fetal heart rate, specifically looking for more than 2 cycles per minute. It reflects that really crucial beat-to-beat variation. Honestly, it's one of the most vital signs of fetal health and nervous system function.
So what kind of variability are we hoping to see? What's good?
We're always aiming for moderate variability. That means the amplitude, the up and down range is between 6 and 25 BPM. Think of moderate variability as the baby kind of physiologically waving hello.
Uh-huh.
It's this robust, constant signal that their brain is awake, alert, and actively talking to their heart, effectively managing blood flow and oxygen. It predicts a well-oxygenated baby with a normal acid-base balance. It's incredibly reassuring.
And what if that wave falters or disappears? What are the concerning signs then?
Well, the most concerning is absent variability, where that amplitude range is basically undetectable. You can think of it almost like flatlining for an adult heart. It's a very serious sign, indicating the baby has no reserve left and is potentially quite distressed.
Okay, that sounds critical.
Then there's minimal variability, which is less than 5 BPM fluctuation. This can be caused by things like CNS depressants given to the parent, maybe magnesium sulfate for preeclampsia, or even certain pain medications. These can cause the baby to sort of chill out temporarily and lose some variability.
Right.
So clinical judgment is absolutely key here to figure out if it's just the drugs or if it's genuine fetal distress.
So if you've just given the parent some pain relief and you see the baby's variability dip a bit, it's not necessarily panic stations if you know the cause. You're looking at the whole picture.
Precisely. Context is everything. Then on the other end of the spectrum, we have marked variability, which is more than 25 BPM fluctuation. You often see this when the parent is pushing hard as the baby's trying to compensate for those rapid changes, but it's generally not considered reassuring because the fluctuations are so rapid and exaggerated, it can actually be a sign of instability.
Okay, so moderate is ideal, absent is an emergency, and minimal or marked need really careful watching and context.
Yeah.
It really highlights how vital this beat-to-beat story is.
Absolutely. And it's crucial because fetuses, unlike adults, can only experience metabolic acid-base imbalances, not respiratory ones. If these imbalances persist, lactic acid can build up in the baby, which, if it goes unaddressed, can eventually lead to that absent variability. So we're constantly assessing, are these changes due to something we did, like meds, or is it genuine physiological distress?
Let's switch gears to something more positive, accelerations. I'm guessing these are good news on the strip.
They definitely are. FHR accelerations are these abrupt, temporary increases in the fetal heart rate above the baseline. This is a reassuring finding. It tells us the baby's nervous system is intact and they're reacting positively to their environment. We love seeing accelerations. They're a great sign of fetal well-being.
Good to hear. Do the criteria for what counts as an acceleration change depending on how far along the pregnancy is?
Yes, they do. For babies over 32 weeks gestation, an acceleration is defined as going up 15 beats above the baseline and lasting for 15 seconds up to less than 2 minutes. For babies before 32 weeks, it's a little more forgiving. 10 beats above baseline, lasting for 10 seconds or more.
Okay, 15 and 15 after 32 weeks, 10 and 10 before.
Exactly. And a good clinical tip. If you're ever unsure whether a little blip really meets the criteria, it's safer to not count it. Basically, make the baby prove its well-being with clear accelerations.
Gotcha. Err on the side of caution. So accelerations are the green lights. Now let's talk about the signals that require caution. Decelerations, these are drops in the FHR, right? And they can indicate potential fetal distress.
That's right. And there are three main types, each telling a very different story about what might be going on. First, we have late decelerations. These are characterized by the fetal heart rate dropping after the peak of the contraction.
After the peak.
Yes. This is generally considered a bad sign. It suggests the baby is feeling the stress, the trauma of the contraction, and isn't recovering quickly enough afterwards. It often points towards placental insufficiency.
Placental insufficiency. So the placenta isn't delivering enough oxygen effectively, especially when the uterus clamps down during a contraction and blood flow is reduced.
Exactly. Common causes might be aggressive pitocin use causing contractions that are too strong or too frequent, or sometimes just an old placenta, maybe in a post-term pregnancy like 42 weeks, where the placenta might have started to calcify and isn't working as efficiently.
Okay, so late's about the placenta. What's the next type?
Next up are variable decelerations. These are kind of unique because they are not necessarily tied to contractions. They often look V-shaped or U-shaped on the monitor strip, sharp dips with more than a 25-beat drop from the baseline. They're typically caused by cord compression.
Cord compression, like the umbilical cord getting squeezed.
Precisely. Imagine the cord just floating around, and maybe the baby's movement briefly compresses it, or maybe the cord gets pinned between the baby's shoulder and the uterus wall. The heart rate dips when the cord is compressed and then usually recovers pretty quickly once the compression is relieved.
Okay, so lane's placenta variables equals cord. What's the final type?
The third type is early decelerations. These happen before or right with the contraction. And here's the good news. This is generally a good sign.
Oh, really?
Yes. It usually indicates head compression as the baby moves down into the birth canal. It suggests that delivery is getting closer, the baby's descending, and its head is getting gently squeezed as it moves down.
Oh, that makes perfect sense. As the contraction builds, head gets compressed, heart rate dips a bit in response, and then it comes back up as the contraction eases. So early decels are actually a sign of progress. Okay, this is a lot, but it really clarifies how to interpret those patterns. All right, so we've learned to identify the patterns, the reassuring ones, the ones that make you watch closely, and the really concerning ones. Now comes the absolutely crucial part, taking action. When you see those concerning patterns, especially those late and variable decelerations, there's an immediate set of things that need to happen, right?
Absolutely. And this is where the LION acronym is just indispensable. It's designed for immediate intrauterine resuscitation. And these actions, importantly, should be started before you even pick up the phone to call the provider. You act first, then you inform.
LION. Okay, walk us through each step. What does each letter stand for?
Okay. L. Turn the parent onto their left side. This is so important. It helps increase blood flow to the uterus, uterine perfusion, by shifting the weight of the uterus off the major blood vessels. L. Administer an IV fluid bolus, usually lactated ringers. This boosts the circulating volume, which also helps improve that critical perfusion.
Left side, IV fluids.
O. Give oxygen via a non-rebreather mask, typically at 10 to 12 liters per minute. This oxygen primarily helps hyperoxygenate the parent, which maximizes the amount of oxygen transferred across the placenta to the baby. And N, notify the provider. This happens after you've started these interventions and you've had a moment to see if they're helping.
So you're not calling asking what to do. You're calling to report, hey, I saw this, I did LIO, and here's what's happening now. That's a huge difference in practice.
It absolutely is. All three things, left side, IV fluid, oxygen, are done together like a rapid sequence, and your charting needs to reflect the specific actions taken and the outcome. Just writing continue to monitor after seeing concerning signs. That implies you didn't do anything, and that can have serious liability issues. You're actively intervening.
That's a really powerful principle. Proactive intervention. Now, about categorizing these FHR patterns, I've heard about the NICHD criteria. Is there an easy way to frame those?
Yes, a really helpful way to think about the NICHD criteria is using a traffic light analogy. These categories basically guide clinical management and tell us how urgently we need to act.
Okay, traffic light. So green light means go, everything's looking good.
Exactly. Category I is the green light. It's considered ideal, indicates routine management. For a pattern to be category I, all the criteria must be met. Baseline FHR between 110 160, moderate variability, no late or variable decelerations, and early decelerations or accelerations can be present or absent. So even a baby that's maybe sleeping and not showing accelerations can still be a perfect category I if everything else is good.
Okay, and red light obviously means stop, emergency.
That's category 3, red light. This is a critical situation. Clinically, you might hear it summarized as, "Mom and baby are okay. If here, do lie in." That phrase, "if here," really emphasizes that the baby has used up its reserves.
Wow.
Every second counts because they have no compensatory mechanisms left. Immediate intervention is paramount. Conditions include recurrent late decelerations, recurrent variable decelerations, or absent variability with recurrent lates or variables, or bradycardia. In this category, those lie-in interventions are absolutely critical, and while nurses don't recommend delivery mode, we should definitely be preparing for it and calling for an immediate bedside evaluation by the provider.
So critical. What's in between green and red then? Yellow.
That's category 2, the yellow light, proceed with caution. This is kind of the intermediate category for patterns that don't quite fit category 1 or 3. It often means a wait-and-see approach, but with much higher vigilance and more conservative management. For example, if Pitocin is running, it might be decreased, or the dose increased in smaller steps, less often. The focus here is really on increased surveillance and actively charting your interventions, essentially trying to keep things from tipping over into category 3.
That traffic light analogy really does help simplify it. Green, yellow, red. Always aiming for green, watching yellow carefully, and acting immediately on red. So far, we've focused a lot on the baby's heart rate patterns, the top line. But the other really crucial part of that monitor strip is the bottom line, the parent's contractions. Understanding these is just as key, right, for evaluating labor progress and the baby's well-being?
Absolutely. They go hand in hand. There are several key terms we use when talking about uterine contractions. First, duration. This is simply the time from the beginning of one contraction to the end of the same contraction. How long does it last? And you can often give a range here, like 60, 90 seconds, because they won't all be identical.
Okay, duration is how long. What about how often they're happening?
That's frequency. This is measured from the beginning of one contraction to the beginning of the next one. You figure this out by counting those 1-minute dark red lines on the strip. Are they coming every 3 minutes? Every 5 minutes?
Got it. Beginning to beginning. And then there's the time between contractions. That sounds like it might be really important for the baby.
Oh, it's vital. This is called the interval, or sometimes the resting tone. This is the crucial recovery time between contractions. It's when the placenta gets properly perfused. It's when the baby gets its oxygen supply replenished. The uterus has to relax completely during this interval for the baby to get oxygen and recover from the stress of the contraction. If that interval is too short, the baby doesn't get enough of a break.
Okay, so that resting time is critical. And finally, intensity. How strong are they?
Right. With external monitoring, remember, intensity is mostly judged by palpation feeling the uterus and what the parent reports as their pain level. Ideally, they tell you both their worst pain during the peak and their current pain level between contractions, so you can kind of match it to the monitor. With internal monitoring, that IUPC gives you the actual numerical pressure reading for intensity.
Okay. Now, what happens if those contractions get a little too enthusiastic? Too much activity?
That's a condition called tachysystole. It basically means excessive uterine activity or overstimulation of the uterus. The definition involves one or more of these, having more than 5 contractions in a 10-minute window,
More than 5 and 10 minutes?
or contractions lasting 2 minutes or longer,
2 minutes, wow.
or contractions occurring within 1 minute of each other, meaning less than 60 seconds rest between the end of one and the start of the next.
Okay, so too many, too long, or too close together. What's the fundamental problem with that for the baby? It sounds like it links back to that resting interval you mentioned.
Exactly right. The big issue is that tachycystal compromises the baby by cutting down its oxygen supply. There's just not enough resting time for the uterus to relax and the placenta to perfuse properly between contractions. This also, understandably, leads to increased pain and fatigue for the parent, and for the baby, it can quickly cause those concerning decelerations or a loss of that vital variability we talked about earlier.
Okay, so if you see tachysystole on the monitor, how do you manage it? Does it depend on how the baby's doing?
It absolutely does. If the baby is not compromised, say, they still have a nice category IFHR pattern. The go-to drug is usually terbutaline. Terbutaline is a tocolytic, which means it acts like a brake on the uterus. It helps relax it, stops those excessive contractions, and gives the baby a much-needed break to recover. It's usually given as a subcutaneous injection, sometimes up to 3 doses, 15 minutes apart if needed.
Terbutaline, the break. Are there any times you wouldn't give terbutaline? Any safety concerns?
Yes. Crucially, terbutaline can significantly speed up heart rates, both the parents and the babies. So if either the parent already has a fast heart rate, say over 115 BPM, or the baby's baseline heart rate is trending up, maybe over 160, we would avoid using terbutaline to prevent adding more stress to their cardiovascular system. Always check those heart rates first.
Good point. Check both heart rates before giving it. And what if the baby is compromised due to the tachysystole,
Yeah.
especially if pitocin is running?
Right. If the baby is showing concerning signs like you're seeing late decelerations and the tachysystole seems to be caused by pitocin stimulation, the very first step is to turn off the pitocin immediately.
Stop the pitocin first.
Yes. That happens before you even start the line interventions or think about terbutaline. You remove the potential cause, then you initiate those vital rescue measures for the baby with lion, and then maybe consider terbutaline if needed and safe.
Wow. This has painted such a clear, vivid picture of the incredibly dynamic, really high-stakes decision-making that happens in labor and delivery. It's so much more complex than just, listening to a heartbeat.
It truly is. Every little fluctuation, every pattern on that monitor strip really does tell a profound story about the well-being of both the parent and the baby. Understanding these patterns empowers caregivers to make those rapid, critical decisions that can genuinely change outcomes in an instant.
And that's our deep dive into fetal monitoring. We've journeyed from the tools used to listen in to decoding the baby's secret language on that monitor strip, getting a handle on baseline, variability, accelerations, and those critical decelerations. We've armed you with the crucial lion interventions, navigated the NICHD traffic light categories, and finally we broke down how to understand uterine contractions, especially the dangers of tachysystole.
Yeah, this knowledge provides such a powerful framework, doesn't it? For appreciating the rapid, critical thinking and action that goes on in labor and delivery. It's really incredible how much information we can get from these subtle physiological shifts.
As we look to the future, it really makes you wonder, how will technology, the advancements in monitoring, continue to deepen our understanding of fetal well-being? But also, how will that human element, the skilled interpretation and timely, compassionate intervention, how will that always remain at the very heart of care? What other hidden stories might these subtle shifts tell us in the future as our understanding evolves? Definitely something to think about.